Uh, the low frequency filter is as 1 hertz and high frequency filter is at 70 hertz, and notch filter is on, and this is bipolar longitudinal with the left side reading on upside. Okay. And it is in blue and right is in the red.
Yes.
And now should I start?
Yeah. Start off. Very good. So you start off. You're happy with the settings? Are you happy with the technical settings of this EEG?
No, it is looking like plain.
No. Okay, what do you mean by that? Any
Sensitivity you want me to adjust? I'll do
Yes,
it for you. Okay. Are you happy now? Anything which should be a concern for you?
Now notch filter is off.
Now notch filter is off. So yeah, okay. So what is that artifact? Anybody? Because we are on artifacts.
50 hertz artifact.
50 hertz artifact. How do you say it's 50 hertz? I'm just going to say that this is a myogenic artifact, for example. Because both 50 cycle artifacts, myogenic artifacts, they're all, high frequency artifacts. So how do you now say that this is only 50 hertz artifact and not myogenic artifact?
It is generalized and same in. But myogenic, it is mostly an anterior and lateral.
No. See, the point is, here it is seen all over. But sometimes, 50 hertz artifacts can be seen only in one or two electrodes, one or two channels, whatever it is. So that alone is not the point. So how will you distinguish between a 50 cycle artifact, which is, versus a myogenic artifact, which is also high frequency? Myogenic artifacts are generally very high frequency. That she said that, the distribution, but the distribution alone need not necessarily, because, sorry? Exactly, that's a very good point. So there's no variability at all. You can see that, from first second till the last is the same amplitude. Whereas on the other hand, when the high frequency and it keeps varying, the amplitudes keep varying, and the frequency also keeps varying. It's never at one frequency. So the same frequency and same amplitude means you have to suspect. So it's a thick, dirty line. You have to suspect that this could be a 50 cycle artifact rather than a myogenic artifact. Not necessarily only the distribution. Remember that. It is the. Now, how do I confirm that this is indeed a 50 cycle artifact and not a myogenic artifact? Somebody else may say, okay, maybe it looks like a myogenic artifact. So how do I confirm it? The simplest way of finding out, and I think it was demonstrated very nicely earlier.
The exact frequency can be measured.
How?
The paper speed can be adjusted.
Page? Okay, so the paper speed. So what do you want us to do now? He's going to do it. You have to tell Neeraj.
Yeah.
Make it slow so that we can count.
So slow means
So you
15 or
expand.
120.
So you expand. Okay. Now, what is happening?
Exactly 50 and
Now you, so that means...
That is a 1 second.
This is
1
3...
second.
Yeah.
This is 1 second.
That is 1 second between the two thick lines, vertical lines.
This is a 200 milliseconds. So count it.
So there are 5 lines, thinner lines between those two thick lines. So each is about 200 milliseconds. 200 milliseconds into 5 is 1000 milliseconds, which is 1 second. So you just count...
1, 2, 3, 4, 5.
Yeah, so it is just monomorphic, isn't it? So the most important thing, this is monomorphic. Same amplitude, same frequency across. So it's monomorphic, same
Sinusoidal.
frequency, same amplitude. And so 10 per line between two lines, between these two lines, 10, 10, 10, 10, 10, 10. So 10 into 5,
50.
50. So that is the most important thing. So the 50 cycle artifact will always have the same, it's a monomorphic and monorhythmic. So that's a very important point. Okay, so that is what it is. So that's one way of, so when you, in a normal paper speed, it looked like a thick, dirty line. That is a very important thing. So one way of eliminating it is, the best way of eliminating is what?
Proper earthing.
No, not notch. Not is
The
what
best
we
way
are
of
doing
eliminating
post
is
processing.
Proper earthing.
To
should-
ensure that the EEG recording room is shielded from external noise.
Yes.
That's the first thing. And the next thing is to ensure that the technical standards by the technologist is of very high. It should be of very high standard. In other words, that the scalp preparation must be good, perfect. The contact between the scalp and the electrode should be perfect. And what should be the impedance? Impedance means
Resistance.
the resistance. What should be the impedance? Ideally, less than?
Less than 5
5
kilo
kilo.
5 kilo ohms. Yes. So that's, so once these things are maintained, then you don't need to use what? Notch. So that's a very important thing. Ideally, notch should be off, kept off. But then, you know, sometimes we are forced to use the notch on just because our environment is not conducive to recording a good EEG. So that's very important. Okay. Now just as a, so now you tell us, what does this page, read this page now.
Okay. That background activity amplitude is very low, and the frequency is
Good. Yeah, so,
frequency
Yes.
in background. It is about beta,
yes. Okay. Beta as well
and
as some theta, mixed frequency, isn't it? Yes, very low amplitude is there
Okay.
in the background.
and more or less it is symmetrical,
Yes.
left and right.
Okay, good.
And on the frontal leads, it is very spiky, means high amplitude, high frequency waves.
So now, is that, so what is that?
This one.
So this is high frequency
High amplitude.
and also amplitude, okay, that's fine, but high frequency and what else is the next one? Is it monorhythmic, monomorphic? Variable, isn't it? So you can see that the amplitudes keep varying,
Yes, sir.
right? So it's irregular,
Irregular.
right? High frequency and irregular, right? Whereas the earlier one was what? High frequency and
Monomorphic it was.
regular. So that's the difference. Now, so what is that particular thing that you're describing? This particular
Third second.
section or segment.
It is mainly localized to frontal leads.
Yes,
And
Yeah, frontopolar rather.
you described it. Yes. So what is it?
muscular activity.
Okay, so it's a muscle artifact. Now, how will it look when you expand the page? See, earlier we expanded the page and then we could see that they were monorhythmic. and
The
monomorphic.
frequency was fixed at that time.
Exactly. So,
Yes.
how will this look? It'll be?
It irregular it will.
Yeah,
be.
let us see now. Just expand
Yeah,
the
yeah.
page and see, we'll see. Oh, yes.
Yeah.
So, you can see, that this is not.
No, 1 second. Yeah, this is the one.
That's the one.
I'll make it 1660. Yeah. This one.
So you can see that it's looking different from the previous one. Got it? Although it's the variable frequency, variable amplitude, and so therefore this is more of a muscle, but it is also containing what?
That spiky type of.
Yes, yes. So that is what are these? Yes, those spiky little things.
But they are localized to frontal leads.
Yes.
What is
so
this?
what are those?
The another lab you go after EEG.
Acha. ECG, no,
EMG lab, you get it.
that's spikes.
Yeah, so what do you call them? Yes,
What?
they're spikes. They look like spikes, yes. But where are they generated?
Frontal spikes.
Is it cerebral or is it extracerebral? That's what we'll have to decide.
But they are not disturbing the background.
Yes.
They are needle sharp,
Yeah. it
less
will-
than 20 micro. Again, polarity principles, they are just restricted to,
Frontal leads.
yeah, but then that can happen sometimes if it is frontopolar. No.
Yeah, it is
So
end
what
of
are these?
chain
What are
phenomenon.
these? Similar to this one. This is the one. It is little more sharpish, single, coming single. These were the muscle myogenic artifact, like what we get in EMG. So if it is a single one, what we will call it as?
Muscle? Yes.
Yes.
Dr. Athanpri that showed, that is muscle
Spicule, spicule.
spicules. Okay, so now you can again come to
Yeah.
the page. Yeah, so that's a difference between
See, this one.
50 cycle
This was the
artifacts
one.
as well as, yes. Yeah, that's good. Now, any other artifact is seen on this page? Any other artifact is seen on this page?
What is happening here?
Eye closer. This is because it is going down.
Okay, so it's going down. Therefore, what is happening? Which direction is the eyeball moving?
When eye goes down, eyeballs are going down, and
Eyeballs are going down.
sorry, eye is closing, eyeballs are going up, and cornea is positive. That positive to negative, so it is going down.
Very good. So that means all of a sudden the FP1 and FP2 are very electropositive.
Positive.
Isn't it?
Yes.
As compared to
Posterior
yes.
electrodes.
So that's why FP2 and FP1 have become suddenly very
Positive.
as compared to F8 and
Seven.
F7, F8 and F3, F4. So
Yes,
that's
sir.
what is happening. So that's the reason why it is going down.
Yeah.
So when input 1 is more positive than input 2, it will go down.
Yes.
Got it? So that's what it is. So that's why that's a Bell's phenomenon. That's the reason why. So okay. What is
This one.
that one?
This one.
Yeah, that particular one. What has happened to that?
Superimposed spiky.
No. This one. This one. This.
Eye opening.
Yeah.
So that is an eye opening
Opening
artifact, and that again the eyeball is now coming
Down.
downward. So the
Cornea
retina,
positive is going down.
Exactly, it's going down, and the retina is closer to the FP1 and FP2.
Again, this one.
Up.
Up.
Eye
So
up.
again closed and opened up. So it was eye closure, eye open.
So you see these. So you see muscle activity which is irregular, high frequency, irregular. Then you see these muscle spicules, and you also see
Eye closing.
movements. That is
Closer
eye
and
opening and eye closing artifacts.
Blink.
Right? Eye
Okay.
blink, basically. Yes. Okay. Good. Yeah. Yeah. Good. Very good. Okay. Now you can see. Anything else? Now, once you have seen these two artifacts, now you'll have to look for something new, something different. Is there something else that is happening on this page?
Out of phase reversal, and this is phase reversal, but it is localized to, this is out of phase reversal,
Okay.
and that is about, after some time there is phase reversal at F7, electrode pop.
Okay. Excellent. Now, why can't that be? See, you're seeing that there's a phase reversal there at this point with the second. Yeah, that's one. Why do you say it's an artifact and not?
It is
why
localized to
extracerebral
one-
and not cerebral.
Localized to one.
Exactly. So there's no field. There's no
Yes.
field to it. So it's just there's a very sharp transient which is there. which
Sir, what is
phase reversal.
meaning of pop? I just know the phenomena, but
Pop means, see, what happens is your electrode is there. If it is not firmly affixed, what will happen is it will collect the potential. It will collect the potential and it will act as a capacitor. So once it is saturated, it will just give the burst of, it will burst off. So you get a very rapid, sharp, like a needle sharp and then a slow decay, like what our calibration was. Calibration we give, so similar it is. It is a single electrode just decaying like this. So that's the reason it is rapid up and then slow decay. They have to just fix the electrodes properly. That means that electrode is loose, impedance will be high. It is picking extracerebral potentials.
Brilliant. That's the way it is. So it acts like a capacitor,
Okay.
and then all of a sudden it will get discharged.
Yes.
And so that's what is happening. So that's right. So that's why. So it is confined to one electrode. Which electrode is it at? Is at fault?
F7.
Okay, so it's an F7 electrode which is at fault. So that's what it is. So what should you tell the technologist, or what should the technologist tell you?
You should fix that F7.
Yeah. So that means the impedance there, it's not fixed properly. So it's a bit loose. That's the reason why it's picking both cerebral as well as extracerebral. So that's what the whole idea is, to not to pick up extracerebral activity. It's better to pick up only.
Artifacts is more about teaching your technologist what to do.
Exactly. So
because
we should
same
know.
area it will happen, and it happens. There will be an electrical discharge, and then it becomes very difficult sometimes, unless it is rectified.
Now,
Oh, okay.
which
P3.
electrode?
P3.
What is the phenomenon and which electrode?
That electrode pop phenomena at P3.
Yeah, good. And what are those?
Muscle spicules.
Ah, that's right. They are muscle spicules. Which muscle?
Frontalis.
Okay, that's good. Yeah, good. Yeah, very nice spicules. You can see that. Yes. Okay, now
Now eye opening.
there's a big. The first this thing is what?
Then muscle spicules followed by eye opening.
Exactly. So
Frontalis.
what does it mimic?
K,
What does it mimic?
K complex.
No, I mean it's just confined.
Spike
there,
and wave.
That's why. So it's important. You can see that it almost mimics a spike followed
But-
by a large slow wave, right? So, but then, what is the difference between this spike and the spike that you're seeing here?
That wave is very slow.
No,
and
that's okay. The
that
wave is very slow.
background is not getting disturbed.
But you see, if it is coming from
Only
a cerebral
frontal.
source, then how will the spike look? Will it be this needle-like? Generally
No,
not.
not so much
This
sharp.
is that's exactly, and it's just taking off and then dropping immediately like that. That never happens generally with the cerebral. There'll be a slightly angulated upstroke, and then there'll be a slower downstroke.
Okay,
Then followed by a slow wave.
slow wave.
So here, the upstroke is very sharp. In fact, it's just like a single line like that, which is going up and down. Then you'll have to suspect that this is not coming from the brain. It is coming from somewhere else.
Right.
And generally, these things come from the muscle that
Muscle.
comes out. Okay? So that's good. Okay. Yes?
We'll go to the next.
Okay. So we'll go to the next one.
Which one?
Whichever you did. Yeah?
Okay.
You can
Should
start.
I read? Okay. This is EEG recording of Mr. Narayana Swami. Age is not mentioned, but the date of birth is mentioned. 55, it should be 67 or 69 years old.
Okay, good.
Okay. And then the settings are paper speed is 30 mm per second, and low frequency filter is at 1 Hz, high frequency filter is at 70 Hz, sensitivity is 50.
50.
50. And notch filter is on.
Yes.
Okay. And that now it is bipolar longitudinal, but the
Good.
right siding set means recording is on up.
Right sagittal.
Right.
Parasagittal first.
Right.
Yeah.
Right.
Okay. So it's a double banana, no, isn't it? Yes.
And
With the
along
right
with it
four-
is settled along with the electrocardiography setting.
Yes.
Okay. Now I am starting. That 1, 2, 3, 4, 5, 6. It is about theta range. That background is in theta range, and
Good. Okay.
it is a slow background. And then symmetry is there. that amplitude is low, frequency is less, but there is symmetry. And
There's something very, very interesting in this. There are two very interesting phenomena that are there in this.
yes.
You
Oh,
just describe
okay.
the first very striking, the most striking thing in this page.
In the frontal leads.
Okay, so that's good. So that's the first thing. Now you analyze that. Read that. What is that?
Okay.
And then you conclude what it is. Interpret it.
Okay.
So describe it and then interpret it. Yes.
Okay.
Make a
the-
full description, as full a description as possible.
Okay.
Yeah.
In bilateral frontal leads, there are spiky discharges,
Okay.
but the first wave is downward.
Very good.
Okay.
So you're describing.
Downward,
Yes.
it means positive. First wave is positive and then negative.
Yes.
Okay. First wave is
So the dominant deflection is downwards.
downwards.
And it's very spiky, isn't it?
Ah,
And then it is overshooting and then becoming negative, electronegative, and then coming back to baseline, isn't it?
yes.
That's the first thing. Now, what is happening to that?
It is very
It is-
rhythmic.
It is repeating itself. It's repetitive. Correct?
Yes.
Right. So it is repetitive.
In 1 second, it is coming in 2 times.
Yes.
2 times per
Yes.
second.
So it is. What is the frequency?
2 hertz.
Okay. So it is about around 2 hertz. Yes.
Okay.
Okay. Good. Is it a fixed interval or is it a variable interval?
No, in 1 second, sometimes it is coming 2 times, then it is coming 1 time, then 1 time.
Yeah, but
It is regular.
It's regular. Yes,
It
isn't
is,
it? It is regular. Yes. Good. It is regular. Good.
More or less regular.
Yeah, it is more or less regular. Yes.
Okay.
Okay.
It
So how
is,
will
so
you
it
describe?
is more or less positive, regular,
Yes.
about 1.5 to 2 hertz.
Yes.
Okay.
Yeah, it's 1.5 hertz.
Yeah, it's about.
Are these
1.5
periodic
hertz.
discharges?
So when something is rhythmic, it's regular. The interburst interval is regular, fixed.
It is coinciding with ECG.
Yeah.
So are these
it is
periodic
electrocardiographic
So
artifact.
that is why. Now, supposing we did not have that ECG.
EKG, I'll hide
Supposing
it.
we did not have it.
If I hide it, now anything else, if you don't see that ECG, if there is no ECG taken in that particular case, it was recorded from ICU, again, will you take it as cerebral or extracerebral? Is
Yeah,
the
No,
question.
just looking
it
at-
is localized.
Ah,
There is no field.
there's no field.
That can happen. That can happen. See, which is the electrode FP to F4. Here it is FP to F8. I say the origin is frontopolar. And why frontopolar? If it is restricted to FP1, F3, and here also FP1. So it is just purely frontopolar. So it still can happen. Beginning of chain, I will argue with you.
But
So-
first wave is positive, no? So we are going negative to positive. Okay. So means FP1 should be negative as compared to FP7.
Okay.
Okay. Okay.
Sir, could it be a misplacement of lead?
Uh,
Frontal lead, slightly more temporal or slightly low?
then
Why do you say that? Any?
Usually, sir, EEG artifact does not come on frontal lobe.
Oh, that way. Okay. So that
If that electrode is loose, that can pick up extracerebral. So that can happen. That will come to know few pages down the lane. If it shows some other artifact related to the electrode, that will tell us. Sometime it can happen. That is more likely rather than both coming symmetrically that much down.
So this is because we are seeing the EC, you can see that it is time locked to it is time locked to what?
to ECG,
To the ECG. So that is why it's a
electrocardiography.
It's an ECG.
Again, it is
artifact.
needle sharp.
It's an-
Like
it's a-
sir has already told, the most important thing, see, everything you have to take into account. The morphology wise, the location, the periodicity. The cerebral periodic complex will not be this much periodic. It's millisecond by millisecond, you say it is the same. It is the same. Afternoon, when we'll show you the EEGs in ICU, periodic patterns, it cannot be this much rhythmic periodicity. So this much rhythmic periodicity, it has to be something extracerebral by a device which is in ICU nearby, which is milliseconds by millisecond, the same drip or pacemaker or ventilator, or it could be something like cardiac rhythm. Yeah, if it is high frequency oscillator, if it is a child, HFO can give rise to this sort. But then yes, it is extracerebral is what we are contenting to. Yes, it can
What
happen.
is the artifact that you were mentioning? Ventilator. Normally, what is the ventilator setting?
Sir, he is telling about this HFO and all which are used in ICU. They have these higher settings of 40, 45 when they are in ARDS in pediatric cases sometimes. That can happen, but yes, routinely ventilator will not be this. Yeah.
Anything which is very, very regular, interburst interval is very, very regular and not fluctuating, you will have to suspect that this could be a.
So again, needle sharp unless proven otherwise. See, 20 to 70 we say for spike and 70 to 200 we say for sharp. Why this has been kept? This is less than 20. It is just going up and down. You can say a single line. And it is, Atma showed you that the classical morphology going up, slow decay, that is what is the physiology. Here it is rapid up, rapid down.
Yeah.
We'll go to the next.
Yeah. And the, yeah.
Yeah, two things sir had said otherwise also.
Yeah. What are those?
This,
That's what. So we said there are two things on this EEG.
Yeah.
So the
Yeah,
first
good,
one
you made us
has been very nicely described.
it can be
And it is
post because the patient is in sleep, background is slow, but it can't be so much regular that.
This one he is saying. See this one, this one, this one.
Sir, can
this
we
one.
tell this as a triphasic morphology?
Very good. Yes. Yes.
Again, is this rhythmic? This one, this one, this one, this one, this
No.
one.
Sometimes it is coming first, then it is coming end of the second.
Yeah, pulse artifact never generalizes.
But it is corresponding to something, no? It is corresponding to, you see, this also has got a regularity. You can see that, no, that is also having a regularity. You see what each of these, no, those, it is, and if you look at it very carefully, no, each of these is corresponding to the T waves. The T waves. So that is also it is also an artifact which is corresponding to the T waves of the
ECG. Yeah, T waves, it is corresponding. See, this is QRS, na? If we say it is EKG, this is a QRS because this is a QRS. So this is corresponding to the T wave. So this could be still EKG artifact. If we change the gain of it, it could be corresponding to the, it is just coming a few milliseconds after the
absolutely
QRS complex.
Absolutely. So
pulse point will be, it is seen in multiple. See, here also we are seeing, here also we are seeing, here also we are seeing. So unlikely to be pulse.
it's maximally in the O1, but it has also got, it is also seen in other leads, and they are all in the same phase at each point. So that means that is definitely it's a.
But the lead placement also, sir, like that EKG artifact is coming in the frontal.
Yeah, that's true. It is coming in the frontal, which is very rare actually. You know, it's just seeing only in the frontal region is rare, but then it can happen sometimes. It's not, isn't it, sir? It can happen.
Posterior one is concerned, one can only give a differential
Yes.
diagnosis because you can't be sure. For example, that also has got intermittently some kind of a periodicity seen in the. So one possibility, as you mentioned, is that whether it's a part of the T wave, but usually such an occurrence is very unusual. Why should the QRS come anteriorly and the T wave come posteriorly? So that is not explained. So one possibility is that whether it's one should give a differential diagnosis of whether the patient, since it's an ICU patient, it looks like that. So it could be some kind of bloods are occurring over the posterior head region intermittently. That's one possibility. And it has also got, somebody told, triphasic appearance.
It is. It has got a
Posteriorly
triphasic
dominant.
appearance.
Triphasic is the other one has to give it. I did not think that that's an EKG or a pulse artifact. The reason being that it is too much dissociated to although there is an interval which is following it. The distribution wise is too much dissociated, one anteriorly and one posteriorly. So if it is connected to the same QRS complex, why is it QRS more anterior and the T wave more posterior? That I think it's one should give it as a pulse or a triphasic wave coming repeatedly in the ICU so that they can be on the lookout for it. And
Here it is looking more prominent.
no, the triphasic waves more often is generalized and more often is anteriorly dominant. But there are situations which can be more posterior. And then you are telling anteroposterior lag. That similarly there is a posterior-anterior lag also. So it's variable. And ED, because many a time the artifact, Dr. Westmoreland used to say she is interested in the Sherlock Holmes and all. So she says that detecting the artifact is something like a detective work, isn't it?
Correct.
Is you have to exclude one by one and then give a DD and then try
It's a
to...
good one. That could be a right hemispheric pathology which is generating some triphasic like sharp waves which are seen in the posterior head regions. Apart from that, there is a EKG artifact which is going on all the time. And in this instance, what are
This
these?
one, 1 second, sir. This one. Go to next page.
There are two eye blink artifact.
Which
Is eye opening.
direction? The eye
opening.
suddenly kind of opened because that's because it's going upwards. It's eye
Upwards.
blink means it will go. That means what? The eye is opening is what when it is
Going up.
Going up.
This,
If the eye is closing, then it will go down. So it looks like as if that particular thing, the person suddenly opened the eye. That particular artifact, this particular one. That one, which is seen. Which is seen on only in the frontopolar regions.
There are two eye opening and one eye closing artifact.
That one, the second.
Yeah. First one is eye opening artifact, and then after 1 second after we can see
There's
eye closing artifact.
one eye closure that is there. This one, the second one, this one. This one. This one.
Yeah.
Yes, sir. Yes, sir.
That's the
Neeraj,
eye
you
blink.
can you put the arrow in the following that second eye opening artifact? You put the arrow in that posterior rhythm which is coming. No, the one in the same in the fronto, in the anterior frontal, the right anterior frontal region, or you can say that the left posterior head region. Beyond the second eye opening artifact.
This one, sir.
That's the second opening artifact. Now you put the cursor in the P301, the next one. What I want to show you is that it's unlikely to be an EKG artifact. Here the relationship between the anterior EKG artifact and the posterior you told is reversed.
Yeah.
For
Yes, sir.
example,
Here
the
it
posterior one is, next one, okay, that one. The relationship between the EKG and that artifact is reversed. No, that one is coming earlier than that.
Correct. Yeah, that particular one is coming earlier.
Connected with the
So which means that there is a ongoing periodic activity coming from the right posterior head, left posterior head region.
In ICF setup, usually you get bilateral independent.
Correct.
Floods and all this kind of, right?
Very good. That's a good one. That's a tough one. You can go to the next one. Let's see. Which one? Yes. I think this is almost a spotter, but again, you can read it very
In systematic way.
systematically. Yes.
Okay.
Yeah. Any other volunteer? You have done a very good job. You have done a very good job. Somebody else can also. She's good, very good. I think.
Anybody else?
Somebody just
Don't hesitate, just commit.
just commit. No, it's good to commit. It's not a problem. See, you see how difficult it is. It's difficult for everybody, and it's important to discuss. So the more you discuss, the better it is. It's learning for all of us.
Sir, this is the EEG of patient. Age is not mentioned. So it's having low frequency filter of 1, high frequency of 70 with sensitivity of 7 microvolt per millimeter with notch filter on. Now it's off.
Yeah.
So the background 7 to 7.5 hertz.
Okay.
Theta rhythm is seen, which is bilaterally symmetrical. And notch filter.
Notch is on.
Notch is
If
notch
we
is
turn
on.
it on, yes.
See, if the notch is off, then you see a lot of 50 cycle artifact, isn't it? There's a lot of 50 cycle artifact. Almost everything is occupied by 50 cycle artifact. Even if you put on the notch, you're still seeing 50 cycle artifact, because every filter, how much does a filter, what percentage of activity does a filter out?
Filter out.
See, if you put 50 hertz filter, what percentage of activity gets filtered out and what percentage remains?
Sir wants to say, like, will it clear out 100%? Will it reduce by 100%?
Yeah, it's about 70 to 80% of activity is
70.
filtered. Still about 20 to 30% of activity will still remain, and that's what is happening here. Despite, so which means that not everything is removed. There's still some residual 50 hertz artifact remaining despite using the notch filter. That's what we are trying to tell. Okay, so there is a 50 cycle artifact which is going on all the time. Yes, maximally seen over the right parasagittal chain. That's what it is.
And
Sorry, right
also
temporal chain.
Temporal chain.
Not parasagittal, right temporal chain. Yeah.
Also, there is fast beta activity in the predominantly in the right frontotemporal chains.
Well, the problem is that there's so much of
50 hertz.
50 hertz
50
artifact,
hertz.
so that is very difficult to tell whether there's separate beta activity. That could be there, but it's very difficult to tell that there is a beta activity generated from the brain that is being seen on this because of the 50 cycle artifact which is dominating the picture. Okay, then what else is there on
And
this page?
in the left frontotemporal chain, there is delta activity with superimposed fast activity over the waves.
Yes, good. Now, where is the activity? Maximum.
So in F7, T3, T3, T5, both the channels are showing the delta rhythm with superimposed fast beta activity over the slopings.
Okay,
So
is it so
looking
now-
like delta brush?
Okay, right. Okay, it is a delta activity, correct?
Yes, sir.
Now you have to tell about the frequency.
So
Then you have to tell about the morphology. Then you have to tell about the rhythmicity.
it is monomorphic.
Okay, so it is monomorphic. That's
monomorphic,
good. Right.
rhythmic, Approximately 1.5 to 2 hertz.
Yeah. So it is monomorphic.
1 to 1.5, 1.5 rather.
See, when you say that when you count the activity, between see these are the two lines, 1 second, correct? Now, one full wave is there, so that means definitely 1 hertz, right? Now, half of this and half of this, so that will combine, and then it will tell that it is 2. For example, here, okay, it's almost 2 hertz because 3/4 of this wave, 1, and almost another 80%. So it's about just slightly under 2, more than 1.5, but slightly less than 2. So that is the frequency that is there. That is there throughout like that. So it's monomorphic, monorhythmic.
Delta activity.
Delta activity.
Now, whether it is cerebral or
With,
extracerebral.
with rhythmicity.
With rhythmicity. Does it have a field?
Field is not there.
Where is the maximum? If you are asked to choose where is its maximum, where is it, which
T3.
electrode is it maximum, what will you choose?
T3.
T3. Okay.
Does
now
it
you'll
has
have,
a field?
Does it have a field?
Sir, field is not there. There is
Field
no
is
change
not
of the
there.
background
So,
in other chains.
exactly. So from first second till the 10th second, it is the same frequency, the same morphology. So monomorphic, monorhythmic, same frequency morphology. And you said that it is confined to which electrode?
Left T3.
T3. Now you have to tell whether this is a cerebral or extracerebral.
Since there is extreme rhythmicity which is there,
Yes.
and so I would first like to rule out extracerebral.
Okay. So
And
that's
there is also field is not there because in the
that's
other
what. So
chains,
based on these two factors, you think that it is not from
And very much regular.
the brain.
Very much regular.
It's very, very
Very
regular.
periodic.
Okay. Now, if it is not from the brain, where else it could be generated from? One electrode. Somebody is telling about, yes, you are saying that it is synchronized with the EKG. But then you saw the previous EEG, it also synchronized with the EKG, those discharges.
But
But they were what morphology?
yes.
Spike.
Spike
Correct?
morph-
It looked like it's a spike. Here it is not spike. Here it is very
It
slow.
may be a pulse artifact.
So, is it an EKG artifact? Because it is in relation to the EKG. Correct?
Pulse artifact.
It seems to occur with the EKG, or
EKG.
there's a one-to-one relationship
And it's
with the
confined to
EKG,
a
but
single point.
the morphology is not like an EKG spike. The morphology is different here. So now what is it?
Can be a pulse
Why not
artifact.
tapping artifact? Somebody wants to know why not tapping artifact.
Yeah,
Why
if
not
somebody can actually tap at the same frequency, at the same amplitude like that, yes, it can, yes. But I don't think any human activity won't be that from
That
outside.
regular.
So that is the difference, okay? So,
And it's
yes,
very
but you got to think of that. Yes, you're right, absolutely true. So what is this?
pulse
Likely to be
pulse artifact.
pulse artifact. How will you confirm that this is confined to only one electrode? We are now assuming that it is involving two channels. It is involving two consecutive channels, successive channels. F7, T3 is one channel, T3, T5 is one channel. So two channels are involved. But you are saying that only one electrode is involved, right? Now I want to confirm that it's only one electrode.
Common average, we can
Okay,
put
so
it
you
on
want
common
to use
average.
a referential derivation, and in that you can choose, say, you want to choose common average. Okay, we'll choose common average. Right. Now what is happening?
So in
Exactly.
this
So it is
only-
now you are sure that this is involving only one electrode, which is T3. Very elegantly demonstrated. Now you don't have the EKG in this particular this thing. Unfortunately, we don't. The EKG is not being shown in this particular derivation, so you're not seeing it. Supposing you had not seen this EKG, would you still be able to say that this is extracerebral and not cerebral? Yes? That
We
is
can
the
say.
important thing, because this is still confined only to
One
one electrode. That is the first thing. It doesn't have a field. The second thing is it is very, very monomorphic, monorhythmic. Whenever you have that, and then you count and see, how many, in 1 minute, how much would it come to? 1, 2, 3. You must always do all these things so that 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 in this page. Right? So how many in a minute?
How many in a minute? 10 seconds it is 12. Yeah, as simple as that. So how much?
Yeah, so that's what it is. So now that you have the EKG artifact, now you have the EKG for you, then you know that, okay, you can then see. You see the QRS is corresponding to the trough. Each QRS is corresponding to the trough, and each of this, the delta wave, is corresponding to the repolarization phase. It is not at the depolarization phase, because it takes a little time for the blood to flow and reach. So the peak, the delta peak will not correspond to the QRS. The delta peak will correspond to the repolarization. That means the ST. So that is a very nicely demonstrated on
sorry.
this.
Yeah. Roughly it is 200 milliseconds after that it starts. So,
Yeah,
so
there's a
every
lag.
time it is just one small, this
So this is
200 millisecond after that it starts and then it peaks. So this is pulse artifact.
In drawing eye movements also there is up and down, up and down.
Oh.
It is localized to one side.
Oh, okay.
This is localized to one side. So, if this can't be rowing by the very
Distribution
definition of rowing means it's slow. I mean, this is too rapid.
That is a baseline sway.
And when the eye is moving so rapidly, it will always have a sawtoothed appearance, just like in a REM sleep.
So more
In
of-
rowing eye is a very slow drift. It will almost mimic a sweat artifact like thing.
So the distribution is also like roving.
Yeah, location.
No, location.
Yeah, of course, if it was both sides, that's what the discussion is about. Okay.
Sir, since it was only on the one side, so like we sometimes see patients where the patient is turned to one side and we get a distribution of the compression of the electrodes, and then also we can see the electrode artifacts in this way, because since it's distributed only in T3.
Sure.
So can we also consider that, because
If the person is lying on one side and
side, like if it is on the T3, so the patient is lying on left side.
Yes.
So there is compression of the specific T3 electrodes, which is
Yes.
causing this rhythmicity and.
yeah, I mean, the basic point is that it is extracerebral, it is confined to that electrode, and there is some very regular movement of that electrode. Something is moving the electrode regularly or is involving that electrode regularly. So then you'll have to decide what is that which can be so regular.
Here is where your role of technician comes in. You sit with them, teach them. So next time what will happen? Like you are saying head is turned, so they will try to see if it is getting compressed. Now if you teach them next time, what they will do is just move the electrode by few millimeters, and if it gets obsoleted, then it tells us what it is. It is pulse. It was pulse because it was overlying that temporal artery, and so it was just moved a few millimeters and it settled down.
Can you go back into that,
Yes, sir.
the one into?
1 second, sir.
I remember when I completed my fellowship at Mayo, and when they give a send-off party, the doctor, I think the present given to me was a divider. Why it is it? So what is your children's instrument bags would have a
The-
divider. And there in the EEG lab, they keep a divider, and that's usually given as a present to the fellows. So what is the, why do you keep that dividers in the, see here the only, I mean the final conclusion, I mean to do is, it has got a relationship to the ECG, relationship to the EKG, but it's not following like the, because of the, what you call the heart to brain circulation time, it's delayed. But what one should do is, ideally either mark it or through the dividers, calculate the RR interval and then try to find out whether it is correlating with the trough or the peak interval. You know, that's a way to prove it. That's
The
how,
divider.
that's how we have been taught to do that.
Excellent, sir. So that's great.
Yeah.
It's a good thing that the differential diagnosis is a TIRDA, but again, the reason we already concluded that it's extracerebral because there's no field.
There's no field. That's
No
the
field.
most important thing.
TIRDA would have a field.
Yeah. So thank you.
In referential also we saw there is no field.
No
to it.
field. It's only confined to one electrode.
Yeah, we're stopping.
Thank you.
Okay, thank you. Yeah, we'll start at 3 o'clock.